Hello, darling.
Hello. Welcome, everybody. My name is Denise Pines. I am the executive producer for Birthing Justice. I am also the co-founder of Women in the Room Productions, which produced Birthing Justice. So Birthing Justice tells sort of places Black women at the center of the fight to fix a broken problem. In the documentary, we tell this story by examining the structures and the systems that detail or sort of lead to the mortality rates that we have heard about from yesterday to today when we see the footage. We also, though, talk about the progress being made. So the progress in health initiatives, the progress through dedicated practitioners like the two that we have here who are also featured in the film, as well as best practices. We cover rural areas, suburban areas, urban areas, and the women and those experiences, from those who are on public assistance to those who have private insurance. The film also goes into a bit of historical context as to why we don't have as many Black physicians today. The goal of the film really is to show that there are solutions and that these solutions can be replicated across the country. So our goal was to tell this story through the lens of both justice, but also of joy, because we believe that every woman deserves a beautiful birth story. And so now we're gonna watch Birthing Justice, which is a 10-minute clip from an 86-minute film that aired on PBS in April during Black Maternal Health Week.
I don't know if you've ever witnessed a birth, but I remember the first delivery room I was ever in as a student nurse. It was a joyful, exciting, incredible experience, and that's something that should be available to every family.
Hi, how are you? Hi, I'm Ebony. I came back just for you so you could check your baby. Okay. Going back on that table. So is this a boy or girl?
Don't know.
Oh, it's a surprise?
Yeah.
Oh, I love that. Oh, until next week? Oh, okay. You guys are really patient.
Yeah.
I wanted to know, like, immediately. Oh, come on, sir. You about to do this work.
When I think about not only generational trauma, but also just the regular habit of trauma, I feel like in this world, in this society right now, I feel like everybody's coming into this life transition with baggage.
So come put your hand right here. So you put your hand where my fingers are. Right, push it in. You feel that little hard thing against your fingers? Mm-hmm. That's the head.
One thing we see in birth is that folks don't always disclose, but unfortunately in that state, in that, vulnerability, things are exposed.
That to you.
And so from our standpoint, we basically treat everybody like they've had some kind of trauma without even asking. It's just way too common.
There you go, that's perfect.
The biggest misconception is there's something that we are doing. There's something inherently wrong with our body, our makeup, our genes.
I'm just joking.
There's something that we're eating. There's some ways that we are behaving, that somehow these bad habits have put us in a situation for poor maternal health outcomes. And there's nothing that we are doing that is so different than anyone else in this country.
So you're good to go. Baby sounds great.
But for some reason, it's always easier to point to individual level behavioral factors as a source of the issue. And we pour so much money into trying to, change what people eat, how much they exercise, what they do. And you can see that poor white women with less than an 8th grade education have better outcomes than Black women with college degrees.
It's not race, it's racism. That's the issue.
The idea that there is a single metric that you can use to determine the health of a society, which is the infant mortality rate. And we have long had a significant disparity in this country for Black babies dying. You know, I never talk about this, but we've had that happen in my family, my extended family. And it was something that as a nursing student, I was really compelled to work on. We are very clear on the problem that we're trying to solve. We are trying to end this maternal mortality crisis. It is the mortality rates for Black birthing people that is driving the United States to lead the industrialized world in maternal mortality in 2022 in the richest nation on earth.
I miss you.
Why you didn't respond to me?
We need more birthing centers. We also need a type of care that's more culturally congruent.
You look absolutely beautiful. I haven't seen you in so long. Your belly. Can I see your belly?
Oh yeah, there's a baby in there.
Look at that belly.
I commonly
That's awesome.
will talk about this with my students and also my staff.
April.
It's not about you. It's about, you know, the families that we're trying to take care of.
So those are all really great positions to labor in and to birth in. You want to do gravity neutral. You don't have to lay on your back, okay? Another great thing to do is you can lean back up against me and we can sway. I know you just like to swing. Yeah. Yeah, I know. So you can lean back on me.
Okay.
And then me. And then
Okay.
just kind of
Sometimes I can feel like you're talking to a stranger about your problems, but with my doula Zoe, I can talk to her about anything. She's there for me. We can laugh together, we can cry together. She'll educate me on my birth, and she'll still be there for me after the baby's born, which is great. Thank you so much.
You're welcome.
It does bother me that a lot of the things that folks talk about are just so negative. And so I do think we need to put more energy to talk about Black joy, right? Because it does exist. There are beautiful births being had at home, in birth centers, in hospitals, by Black birthing individuals that are fabulous and joyful. So let's shift the narrative. Let's share great birth stories.
Jasmine. Hi. And I think I may have told you my name up front, but I'm Oko Shola.
Nice to meet you.
It's powerful for people to have a Black provider who not only looks like them, but share lived experiences, who has had an accomplishment on the other side of trauma.
All the ways that we show up every day, we think about, but just become like this normative behavior. It all kind of cumulatively shows up in how we birth, right? So if, you know, my husband who would like to wear t-shirts and sweats to a doctor's appointment with me, instead he is like, wait, let me rethink this, and he goes and changes into slacks and a collared shirt and a V-neck sweater so that he's seen visible. Those are just some of the ways that we have to navigate something that should be so joyous and sacred.
We are really, really trying to dismantle the system and rebuild it and make it something beautiful and new. We're also going to stop blaming women and like blaming birthing persons. Get rid of that blame narrative. I think folks need to do also their own individual work, but also like the systems. Call out wrong. Take a stand. If you really want to also help in this movement, in these challenges, you got to call people out.
When African Americans are centered in policymaking, it affects everyone. Fear anger, shame, othering, being ignored, being lied to, being dismissed, being discriminated against, being fundamentally disrespected should not be anywhere near this. And you can have joy and justice together. That is possible. We're talking about changing culture, and I know that within our healthcare system, joy is not necessarily a foundational premise in every healthcare system in this country, on every birthing unit in this country. And so I'm okay with creating a caucus and legislation and a safe place to say, oh, this is what we're about, is bringing joy.
Okay, let's get you set up. I know it.
One thing I probably haven't said enough of is like, listen to Black women. Listen to Black women in leadership. Listen to Black women who are in these communities who are telling you, listen, and we will tell you what we need. And I feel like there's also been such a movement now for Black-led organizations to also push to be like, hey, we just got to do this ourselves. We got to take care of ourselves. And I'm excited. Like, I have, in the last 5 years, gained so many different colleagues in the fight, in the movement. I just feel like that's even such a shift that I'm optimistic.
It brings me joy every time we have positive birth stories. Those moments bring me so much joy, and they're little nuggets sometimes, but they're so huge.
Major funding provided by W.K. Kellogg Foundation, a partner with communities where children come first. Robert Wood Johnson Foundation, building a culture of health for America. Missouri Foundation for Health, a catalyst for change. Patty Quinlan through the Meadow Fund. Additional funding provided by
Good afternoon. Thank you so much for joining us at Aspen Ideas Health for today's conversation, Birthing Justice, the Maternal Mortality Crisis. Now, you have already met Denise Pines. As she said, she is the co-founder of Women in the Room Productions and the executive producer of the PBS documentary, Birthing Justice, which you've just seen a clip from. I highly recommend that you go find the full version and watch it for yourselves after this conversation. I will also introduce you to the rest of our beautiful panelists. In the middle, we have CEO of the MLK Community Healthcare Health System in South LA, Dr. Elaine Batchelor. Can we give it up for Dr. Batchelor? And then to my immediate left, we have the Director of Midwifery at Community of Hope, whose family health and birth center benefits from a 100% Black staff, Dr. Ebony Marcel. Yes, we love that. Absolutely. Now, Denise, I really do want to start with you. You have executive produced projects that exposed the criminalization of Black girls in schools and discussed the history of enslavement in Jamestown. Why was the maternal mortality crisis the next story that you wanted to tell?
Because the statistics are outrageous. I mean, the statistics haven't changed in almost 35 years.
They're getting worse.
They're getting worse. And, you know, I would say that we can clone a kitty cat, but we can't deliver a healthy baby, and the mother can live with that healthy baby. There's something wrong with our society when we allow that to happen at the level of which that is happening today. So as a storyteller, I wanted to really unveil what is happening. You know, I wanted to see what the statistics were and what was behind that veil. And also to have this film to be used as a tool for people to create awareness, to use it to understand, to use it to discover best practices, to use it to know who people are who are leaders, healthcare practitioners like Dr. Batchelor and Dr. Marcel, who are leaders in this space, to come to them, right? To come to them and get help in this area.
Yeah. And Dr. Batchelor, you make an excellent point in the film that this is a healthcare crisis that is not only affecting Black birthing people, but it's also emblematic of deeper issues within our overall healthcare system. Can you talk more about why everyone should be concerned about this, whether or not it directly affects them?
Well, we're all linked, and in some ways, the problem of Black maternal mortality is a canary in the coal mine, you might say, because our country has worst outcomes for all women who are birthing. So we have a much higher rate of both serious morbidity complications and mortality for women in this country than in all other economically developed countries. So we're not doing very well with that. And the disparities that we see in maternal health are also similar to the disparities we see in general health care. So I lead a private safety net hospital and health system that serves a low-income community of over 1 million people of color. Our community is severely under-resourced and suffers from poor health and large health disparities. As a community, we're missing 1,500 providers compared to other communities. And it's rooted in policy decisions that are being made in this country.
Yeah, absolutely. Now, in our conversations leading up to today, we discussed how, as you're saying, disparities in funding are strangling the potential of innovative hospitals and birthing centers across this country. Dr. Marcel, can you speak to the issue of having to rely on grants and how financial support could be better allocated for these services?
So for me, it's painful, right? So here we are trying to be innovative, do things differently, and like I always say, you know, what we have been doing is not working. So we gotta stop trying to put force and funding into things that we've done for, you know, decades. And so here we are trying to do something differently, like add care coordination, pay for group prenatal care, and forced to be at the surrender of how long that grant's gonna last. And you know, I like to joke a lot of times, but grant funding has also changed in the sense that there's a lot of restrictions, and I almost think that they want Jesus' tears in their report when you turn it in. Y'all laughing because you don't tell them the truth. But these are things that our system should pay for, especially since it's going to give better outcomes and actually save them money, right? So we know that the midwifery model of care can improve birthing outcomes. Vaginal births are cheaper than C-sections. So, you know, I'm very, very frustrated with being so dependent on grants, and I'm hoping that, like, we get to a place when we're not.
Yeah. And this financial issue runs really deep, because when I was watching Birthing Justice, I feel like everybody's really familiar with the concept of like a food desert, of not having access to a grocery store in your neighborhood, something where you can get fresh food, fresh vegetables. There are people living in OBGYN birthing center deserts where they don't have access to the care that they need for the children that they are trying to bring into the world, the children that they are presented with to bring into the world. Can Dr. Batchelor, Dr. Marcel, can you talk a bit about how, because you're relying on grants, because no one's really stepping up with the funding that's needed for these programs, whether it's to fund bringing more physicians of color, we talked a little bit about culturally competent care earlier here at Aspen Ideas, but how all of that's interconnected and how it's leaving people high and dry.
Yes, so we practice in one of those healthcare deserts. The majority of patients in our community are low income and dependent on an insurance program called Medicaid, Medi-Cal in California. Medicaid pays lower rates to providers who take care of poor women. As a result, we don't have enough providers in our community. In our emergency department at my hospital, women come in for pregnancy-related care, and our emergency doctors have become their de facto providers. They even schedule follow-up visits for pregnant women in the ED and do routine prenatal ultrasounds. This is all rooted in policy decisions that we've made to perpetuate a separate and unequal health system with Medicaid funding that simply isn't adequate. Part of the solution needs to be more investment in healthcare infrastructure in low-income communities, including a diverse workforce and adequate payment. Ebony's organization should not have to depend on grants.
And you're the only organization in DC, I believe?
So we are DC's only freestanding birth center. We are also one of 3 federally qualified health centers that has a birth center in the nation, which is a really, really beautiful model. Thank you. That we need more of. And I just wanted to, for folks who are not familiar with DC kind of makes a diamond. And the top half of the diamond has all 5 of the hospitals. Right? So now that tells you where the money is. And one of the hospitals, there's actually gnomes. I'm just kidding, there's not gnomes. But there's a juice bar, a piano man. And then at the bottom half, where the majority of my community comes from, there is no hospital. And on average, it can take them up to 2 hours on public transportation to get to their appointments. So what are you gonna do? Then there's other policies and barriers, like you can't bring your other children. Are you gonna get care? No. So one thing that really, really has been transformational is we had a short-term grant, here we go, where we were providing rides. And it was incredible. To say, hey, I haven't seen you in 2 weeks, you haven't been able to get here, cool, here's a ride. I'm gonna send the message to your phone. Even small things like that are so, so impactful, and we need it. And now, the grant is done.
I also want to circle back to what Dr. Batchelor said earlier about us being late. We're late, but we're not too late, but we are very, very late. I was thinking about in Birthing Justice, where Denise so aptly, there's a whole section about historically Black colleges and universities. And I think it's the Flexner.
The Flexner report.
Yes, and how it essentially disappeared 8 out of 10 historically Black colleges and universities, their medical programs, because they weren't associated with a university, I believe it was?
No. So the Flexner report was commissioned by Carnegie Mellon at the time in 1910. And it was done with, really the objective to formalize medicine. At the time, there were about 166 medical schools across the country, and everybody was kind of doing their own thing. So there wasn't really a standardization of processes in all kinds, from hygiene to types of equipment to be used for surgery. And so that report, as it looked at also the medical schools that were at historically Black colleges, looked and classified them all into different categories. And basically, the Black schools went into the category D, you're done. And only 2 were able to remain, and that was Howard, which still exists today, and Meharry, which still exists today. And basically what that did was it eliminated the pipeline of Black physicians in this country. That really has not been restored to this day. So instead of looking at those medical schools and saying, we need to, and this was also in the report, that what those schools needed to do to come up to standard, they made decisions not to do that and just to take their accreditation away. And then that ended, obviously, the medical school, because who's going to go to a medical school that's not accredited? Nobody.
And funding. The funding.
And funding.
Schools are
Yeah.
And in losing the potential of those Black health professionals, we're also losing advocates in those rooms. Dr. Marcel, can you talk a bit about, well, one for people, I feel like people tend to conflate doulas and midwives, so speaking to a little bit of the difference there. And then the importance of having that type of advocate in the room, especially one that can relate to your experience when going through this very beautiful but also potentially dangerous process.
Absolutely. So the midwifery model of care, and this is no shade to doulas. Doulas are very necessary. They're necessary from fertility, death, postpartum, all the things. But the doula is focused on the birthing person. I'm a clinician. I take care of, birthing people through the lifespan. I provide newborn care. A lot of people didn't catch that in the film. I'm doing the baby's newborn visit. I prescribe drugs. I, provide birth control. So it's a lot more expansive than a profession, even though on TV they kind of always put us in the field with Birkenstocks and a flowy skirt. It's definitely a very, very expansive profession. And just to kind of speak a little bit to, the medical schools, the eradication of the granny midwife is another discussion that we need to talk about. Granny midwives were community leaders. They delivered everybody's babies. And they were also pushed out with the influx of the public health nurse. And so when I think about how I'm practicing, how I'm engaging in care, I'm channeling my granny midwives, so my care looks different. Automatically when that person walks in the room, their cortisol level drops because they're like, okay, you look like me. And then, things like being able to talk to them about things that I already know that they're experiencing, or they know that I've experienced, challenges with their jobs, challenges with their schools. It makes a huge, huge, massive difference. And so cultural congruency in care has been something that's been a little touchy. And I like to really, really remind my non-melanated health community not to worry. We can't take over. We only make up a small portion of all the professions, so it's not gonna happen. However, we should endorse, we should support, we should fund when those opportunities can exist because they're impactful.
Absolutely. Birthing Justice does a good job of putting faces, names, and stories to those statistics that we've been talking about here today. And I feel like that's so important when drafting and promoting legislation around these issues. What are some current bills that people in our audience can go home and lean on their local politicians to help change this problem, to help eradicate this crisis?
Well, one, I think just supporting the national act, which is the Omnibus Act, which has been reintroduced, I think, just recently. Supporting that, because inside that act is basically 12 bills. One of them actually passed, and that was the support for veteran birthing people. But the rest of the act actually, supports, all the sort of wraparound things that both Dr. Batchelor and Dr. Marcel was talking about, like housing, safe housing, paid leave, nutritious food, access to care through transportation, if that's what's needed. So that bill actually, sort of looks at all of the social determinants and supports those issues that are also causing a Black woman, not to have a beautiful birth journey that we are looking for her to have. In other states, California has an Omnibus Act that's passed. In New York, they've passed a healthcare protection, maternal protection act. In Minnesota, they've passed one. There's a couple that have passed in Georgia, and there's a lot of other states that also have bills that are currently on the table or on the docket. Some have been, sort of readjust, but in every state, they're trying to put forth something. So to look at what your state is doing and to see what you can do to support it.
Yeah, absolutely. And voting is so important, but are there other ways that you're hoping that Birthing Justice will impact audiences and be a call to action for people when they sit with this bill?
I'd like to see everyone advocating for equitable access to health care and insurance coverage for everyone in this country. Whether we call it Medicare for all, universal coverage, the Affordable Care Act, we know there are still many states that have not implemented the Affordable Care Act yet. And in some of those states, it is going to the voters and to legislators that can be encouraged to vote for it. But we also need to advocate for parity and for not maintaining a separate and unequal system of health care for poor people in this country.
Can I add one thing? Postpartum expansion, right?
Yep.
If you're in a state that they have not extended it for the first year, especially knowing that almost half of maternal deaths happen in the postpartum period, that's outrageous. So that's one thing, definitely postpartum expansion.
Absolutely. The fight to save the lives of Black birthing people is so complicated and so emotional, but it's so deeply worth it. And Birthing Justice does a great job of also offering the audience examples of Black joy and showing how like joyful and important, like that's why we're trying to eradicate this crisis, because there's so much joy on the other side of it. Mm-hmm. And Dr. Marcel, I feel like you're the perfect person to give us a joyful birthing story.
Okay. How much time I got? Anyway, so for me, joy looks like a family having an experience that they probably would not have had somewhere else. So out of the 400 plus birth centers in this country, about 15 accept Medicaid, and probably about 15 are Black owned. And so we are really, really a gem because we're a birth center. We also accept Medicaid. And out of hospital birth can be transformative. And we do deal with a lot of families that maybe deemed high risk, but they're more so high risk socially more than they are high risk medically. So birth center is a beautiful option. So one of my favorite birth stories, I had a young woman who everybody in the office said she was like super mean. She was. But anyway, she came in, and what I loved about her was like her parents was very like, this is who I am, and like she had all these beautiful tattoos and like piercings, and with the like tough exterior, which I understand why she had it. I know that people would treat her funny in different spaces. And here we got to have this like really incredible birth center birth. She was the first in her family to have a birth center birth. And there was this moment that I was sharing with you where she was like on hands and knees trying to push out her baby, but in one arm she had like her husband, and one arm she had her sister, and from the back it looked like she was making a heart. And then like the birth assistant was on one side giving counter pressure, the doula was on the other side giving counter pressure, and I'm at the perineum. Y'all, that's where the baby come out. I'm at the perineum where we're waiting for this baby, and like there's all these Black hands on her. And that baby came out with so much joy, and I swear to God, she smiled. But like, those are the moments that I like live for, because I know if she went somewhere else, somebody would have been frustrated with her or not treated her the right way or given her the opportunity to have a out-of-hospital birth.
Mm-hmm. I told y'all it was a good one. Now, I've been really economical with our time, but I think we might have time for audience questions if we have one or two outliers. Maybe right here in the front. I think we're going to hold for a moment. They're going to bring you a microphone. And then you'll just stand, state your name, where you're from, and then offer your question for our experts. Right here in the front.
Hi, thank you all. I'm Michael Stubbs, and I live in LA. And, you know, I hear LA in California, we have the funding, we have the bill passed. MLK, why is MLK not getting the funds that you need to provide the services? I mean, if it's not from the state, if it's not from the feds, is it county, is it city? How do we ensure that in my backyard, women are able to get the care that they deserve?
Yeah, that's quite a question. Maybe we can meet for coffee afterwards. We can talk about it. So if I have to break it down into, you know, like the simplest answer, I would say it's Medicaid. You know, Medicaid is an insurance program that pays pennies on the dollar compared to what Medicare and commercial insurance pay. And that's particularly true in California, where we have among the lowest Medicaid payment rates to providers in the country. So California has made some interesting policy decisions. They've decided to cover as many people as possible, which is wonderful, and we've done a great job of reducing the number of people who are uninsured by getting everyone into the Medicaid tent, and by providing generous coverage of services, including things like doulas that are now covered, and navigation for housing for homeless people. But they're paying pennies on the dollar to providers. So this coverage has become illusory. And there simply aren't enough dollars in the Medicaid program to support a community of concentrated poverty that is completely dependent on Medicaid. Most communities have a mix of insurance. You know, they have a mix of Medicare, commercial, and Medicaid, and high commercial rates subsidize lower rates from Medicare and, you know, low rates from Medicaid. If you are a Medicaid community, you can't do that cost shifting. And that means you're just struggling to provide care. One other odd thing about it is that there's a lot of supplemental funding for care that takes place in a hospital, but there isn't adequate funding for care in the community. That means that I get paid adequately to amputate a diabetic limb, but I don't get paid adequately in my medical group to provide prevention and disease management to prevent that limb from being amputated. The #1 surgical procedure in my hospital is diabetic amputations. That reflects a failure of community-based care and a failure of the funding system.
I think we have another question right up here in the front. And you'll also stand and give us your name.
Maria Rodriguez Alcalá with Harlem Forward. For Dr. Marcel, with the broken system we have right now, and believe me, I understand your pain with grants, can your model be replicated right now, like in states like Arkansas, Mississippi, where we operate?
Absolutely, but in that model, it has to have a development arm in order to have a concentrated team to dig and find and get those grants. Like, we're definitely not going to get paid for by what we receive from the feds. Like, we still really, really thrive off of not only grants, but philanthropic, you know, funds, which, please, if you ever give money, make it unrestricted. Make it unrestricted, please. We have enough rules. But yes, and I'm hopeful for that. And for those who are not really familiar with our model, what our model looks like is we have a midwifery model of care in a federally qualified health center with a birthing center that also includes integrated emotional wellness. I have dental at 2 sites. I have housing. I have prenatal care coordination, patient navigators. There's a lot of people doing a lot of things because what folks need is they need a big hug in this process. And, you know, I think that absolutely it could be replicated.
We have maybe back here.
Hi, excuse me. Hi, I'm Heather Lane. First of all, thank you so much. This was amazing. I really appreciate it. And I also appreciate the work that Black women are doing to, you know, to solve this problem and to push it forward. You know, but it's often pointed out that racism isn't a Black problem, it's a white problem. And as you know, right, like, you know, your patients, if they go see a white provider or not, can be treated the same. What can and should we be doing, you know, in the white community to be improving the situation?
You know, I can't wait to jump on that one.
Okay. I got a couple of things to say.
Okay. Wait, you go ahead. I've been talking a lot. You go ahead first.
I also wanted to follow up on the last question because I wanted to say that, you know, what we do in our health system can also be replicated across the country. We are located in a community of color. 90% of our workforce is people of color. And we are a high-tech HIMSS 7 hospital that is also a CMS 5-star hospital. Our goal is to provide the same quality of healthcare that people get in every other community. And unfortunately, we regard that as a radical act of social justice in this country. So we all need to rally around providing the adequate financial resources for every community to have a full continuum of care. One other issue that we haven't touched on yet, though, is bias and discrimination in healthcare settings, which means that Black women often don't get the care they need. It means that they're often ignored and disregarded, even when they ask for help. And I can tell you that even as a physician, I have had this experience when I or a member of my family need medical care, and my medical colleagues treat me the same way they treat every other Black woman. We need a more diverse workforce, and we need to do a deeper dive into the experiences that people of color have in the health system. You know, I really appreciate the expressed desire of every healthcare system to be better at diversity and inclusion, evidenced by all of the diversity officers, the diversity statements, the diversity initiatives that have been launched. But I really wish people would do a deeper dive into understanding the problem. Surveys like the survey that was recently funded by the Robert Wood Johnson Foundation that looked at the experience of Black nurses in the healthcare system. A survey that was funded by the California Healthcare Foundation that looked at the experience of Black residents in California in the healthcare system. Or the work of Dr. Kimberly Gregory, an obstetrician at Cedars-Sinai, who has led the childbirth experience survey that surveyed 2,700 women and looked at their experiences. So I think the first thing that you can do is learn more about the problem.
Right. I'm gonna trail on to that, and like, implicit bias trainings, 2 hours are not gonna make people less racist.
Nope.
So let's just get rid of that. But I also feel like it was a little bit more palpable for people to kind of feel comfortable being like, all right, we gotta address racism. I'll go to this class. But honestly, it's bigger than the individuals. It's so layered, it's so deep, it's happened for so long. We gotta look at our systems, you know? So what do I ask from my colleagues? Because I have beautiful relationships with plenty of individuals who help care for my community that do not look like them. And they are likely very aware of their own individual, but also have done the work to understand how this system has wronged a lot of Black communities and work on how they engage with patients. And it doesn't get fixed with quick colloquialisms or talking about a quick rap song. By the way, not all Black people listen to rap. It really comes from that like intention and integrity, and that can be felt. We can feel when it's genuine. And so, you know, definitely, that work is hard, it's painful. It also includes calling people out. Sometimes it's your family, sometimes it's your coworker. It's looking at your systems that you're working in. Why is anybody in this place saying it's okay for people not to bring their children? Why hasn't anybody in that organization stood up to be like, this seems wrong? We gotta change that. But it's things like that that we need as support. And I'm not gonna say allyship, that still goes with that whole DEI foolishness. But yeah, you know, all of those things.
One of my favorite, I'm sorry.
I was just gonna add to it. So I'm the immediate past president of the Medical Board of California, and during the time that I was there, a number of Black doctors had come to me and some other board members saying that they believe that racism existed in the decision-making of discipline, in that they either got more severe discipline or that they were actually disciplined for things that their other colleagues weren't disciplined for. So at first, you know, we looked at our data and we felt like, no, we didn't really see that in the data the way we were looking at it. But we went and got a third party outside to come and evaluate. When the evaluation was done, in fact, it was true. It was true that there was disparities amongst Black doctors, but it was more severe against Latino doctors. And so what we did was we looked at every part of our processes, right? We looked at the judges, we looked at the investigators, we looked at the district attorney's office, we looked at the board, we looked at the general staff who inputs information. We looked at every touch point to see where is it that a disparate thought could occur, even around age. And we took it all out. So in our cases, I used to be able to read where Dr. Batchelor went to school, and she went to Harvard, which she did. I would go, ooh, well, maybe her infraction wasn't so bad, right? So we removed education so that wasn't a bias for us. We removed how old you were. Because if you made a mistake and I could see you were a 72-year-old doctor, I was like, oh, you need to retire, right? I mean, this is how we think, honestly. So we have to accept how we actually do think. And so we removed as many of those kind of barriers. So when I got a case, that I can just look at the facts of the case and make a decision about the facts of what the performance of that doctor was, and make a decision based on that, removing everything else. And that was very extensive, and that's very intentional, and that is what Dr. Marcel is saying. We have to look at the entire structure and piece by piece go through it. And it's going to be uncomfortable because some people aren't going to want to do it. And of course, we had implicit bias training. The judges had to do it. Everybody had to do it. And we had to do it over every 4 months, over and over and over and over and over. And that's what we did. Yeah. It's better. Mm-hmm. It's better. Yeah.
That person has been waiting for a minute. I know the struggle.
Hello, my name is Jaden Nienhuser. I'm from the University of Nebraska, Omaha. I'm an undergraduate student. And in the last 2 years, I've had the privilege of volunteering with the Malone Maternal Wellness Center in Lincoln, Nebraska, which is a wellness center that specifically works to dismantle systemic racism by providing doula training, scholarships, as well as quality maternal care to Black women and initiatives that hold cops accountable and provide universal pre-K for Black mothers. I thank you so much, Dr. Marcel, for mentioning money tied up in grants, because that is just such a huge problem. And with money tied up in grants and money that is coming from donations and is very variable, how can small providers of health for Black people keep the lights on? I mean, there's just so much funding that is given out, but it is for explicit purposes and tied with all this red tape. And all of these smaller initiatives can hardly keep the lights on in the building, hire janitorial services, or even make sure that the buildings that they are working in are sanitary.
Right. Well, I want to give everybody $1 million and a puppy, but I don't have like the greatest answer for you. Like, and I know that my understanding is really, really focused on DC, and I don't know what's going on like in other states. But I think that one of the things that's gonna be helpful is when I have opportunities, I'm talking about the challenges with grants. I'm talking about the restrictions. I'm talking about how they want me to birth a panda. Like, I'm talking about all the different pieces on how we're not able to do that work. But we still also need work with policy. Like, Medicaid, for example, in DC pays $780 for a birth. I said 780. So sometimes we're with people for 3 days. That's a lot of manpower, right? We still have so much work to do to also look at who's paying for what with this government, like what the state is doing. But I don't have the most brilliant answer for you. Sorry.
I think we have time for one more in front.
I just wanted to call out, or call in and call upon the National Commission to Address Racism in Nursing. They really are giving us some helpful guidance on how to have these uncomfortable conversations, and then also the work of Aletha Maybank, who's at the AMA, who runs the health equity work. There is a concerted effort, a commitment for this to be a long-term. So I want to make sure that we have hope in those conversations of racism. And again, thank you so much for all of your work.
Do we have a question?
Yeah, there's definitely hope.
Maybe back here on the right side.
Thank you all so much for your work. My question, I've had the privilege of learning from a number of reproductive justice leaders, not just about the importance of supporting Black women in their birth, but also much earlier on when they might not want to be having children. And you spoke about prescribing birth control, which is awesome. I was just curious if you could reflect on some of the other services that you might support Black women in beyond that period of.
You trying to say abortion?
And
or talk about
control
it
too. Any of it.
Because abortion is healthcare.
Heck yeah.
I'm not. I'm tied. Like, no, I'm not. And we have started even trying to visit that opportunity. But yes, we do need also providers who are also to help people who don't want to have children. But yeah.
All right, I think we're coming up on the end of our time, but can I have a round of applause for all of my panelists, please?